Hello everyone. Welcome to the recall session of INI-CET May 2025 medicine questions. Let's get started. Moving to the first question, which of the following is the earliest presenting symptom in a patient with multiple sclerosis? The options are sensory disturbances, ataxia, vertigo, and facial palsy. So, multiple sclerosis, as you all know, is a demyelinating disorder affecting central nervous system. This question is very specific. The examiner is asking you regarding the earliest presenting symptom. Now, in MS, depending on where the demyelination is, the patient can have varied symptoms. And out of the spectrum of manifestations that can occur in multiple sclerosis, I have always told you in my lectures, two dominant presenting manifestations are number one, sensory disturbances, and number two, optic neuritis. Remember that? Yes. So if you look at this table from the Harrison's textbook of internal medicine, you can see the spectrum of manifestations of multiple sclerosis, and they have highlighted the initial symptoms. And as you can see in this table, sensory loss and optic neuritis are the dominant initial symptoms. Sensory loss in case of 37% of cases, and optic neuritis slightly below 36% of cases. Now, sensory loss in the form of paresthesias, pins and needle sensation, numbness, all these can be initial symptoms. But many a times these are neglected by patients. If you look at this particular paragraph from Harrison, you can see the highlighted part. The early symptoms of MS may be severe or sometimes so trivial that a patient may not seek medical attention for months or years because certain sensory symptoms might be neglected by patients as vague symptoms they may not sometimes report initially, which is why we always keep talking about optic neuritis as a dominant manifestation. However, the initial symptom is mostly sensory disturbance. Now, when it comes to optic neuritis in MS, it is usually unilateral loss of vision with pain on eye movements. Yes, all right. Now, for this question, the examiner did not want to trouble you by adding the additional option of optic neuritis. He has kept this simple for you. What is going to be the answer? Sensory disturbances. Though ataxia, vertigo, facial palsy can all be manifestations, the earliest presenting symptom among these will be sensory disturbances. Hope it is clear. Let's go to the next question. A 20-year-old male presents with fever, severe headache, vomiting, and photophobia. On examination, he has neck rigidity and a positive Brudzinski sign. CT brain reveals hydrocephalus but does not show any evidence of bleed. The question is, what is the most likely diagnosis? What are the options? Option A, normal pressure hydrocephalus. Option B, bacterial meningitis. Option C, viral encephalitis. And option D, subarachnoid hemorrhage. These are the options that you have in hand, right? Let us try to analyze this question. So it's regarding a male who has presented with fever, headache, vomiting, photophobia, and neck rigidity, positive Brudzinski sign. So fever, headache, neck stiffness. This is the typical triad that you all know of meningitis. Correct or not? Typical triad of meningitis. Right? Okay. Now, the patient has also got hydrocephalus. We all know that as a complication of meningitis, patients may develop hydrocephalus. Correct? Yes. So what is the most likely diagnosis is being asked, right? Let's see the options once again. Normal pressure hydrocephalus. I am eliminating this option. Why? Because you know that normal pressure hydrocephalus typically presents with the Hakim's triad. The Hakim's triad, of gait impairment, which is usually a magnetic gait, urinary incontinence, and dementia. That is the Hakim's triad of normal pressure hydrocephalus. Got it? Right. So this patient does not have those symptoms. I'm eliminating this. Bacterial meningitis, yes, I think this is a bacterial meningitis which is complicated by development of hydrocephalus that can occur in patients with meningitis. So I think that is the answer. Let me just go through the other options as well. Option C, viral encephalitis. Well, neck rigidity positive Brudzinski sign. That definitely tells me there is some sort of meningeal irritation. Yes. And in case of encephalitis, it is the parenchyma that is getting involved rather than the meninges. And you can see that the hydrocephalus, that again is not very common with the viral encephalitis. How does patients with viral encephalitis present? Initially, there may be a couple of days of low-grade fever, followed by altered sensorium, recurrent seizures. That is how patients with viral encephalitis presents. But the spectrum of manifestations given in question is not favoring viral encephalitis. Also, the imaging is also not suggestive. You know that in case of herpes encephalitis, you can have involvement of the frontal lobe, temporal lobe, maybe some areas of hemorrhage may also be seen. The imaging is also not consistent with viral encephalitis. Option D, subarachnoid hemorrhage. Well, subarachnoid hemorrhage can present with headache, can have neck stiffness as well because of meningeal irritation. But fever is not common with subarachnoid hemorrhage. And also, the imaging clearly shows there is no evidence of bleed. So I'm eliminating that option as well. The answer is going to be bacterial meningitis. Coming to the next question, which of the following brain structures is primarily involved in explicit memory formation? So in my neurology lectures, I've highlighted about memory, about explicit memory as well as implicit memory. The question is on explicit memory. So what is the basic difference between explicit and implicit memory? Explicit memory requires your conscious effort to retain the information, like episodic memory, semantic memory. These are all examples of explicit memory. Whereas in implicit memory, it does not require your conscious effort to retain that information. For example, procedural memory, riding a bicycle. Okay, that is implicit memory, right? So coming to the question, it is specific on explicit memory formation. You all know how important is hippocampus in explicit memory, especially in episodic memory. Okay, so hippocampus is going to be the answer here. I can also show you this image from the Ganong textbook of physiology, showing the components of declarative, also known as explicit memory, and non-declarative, also known as implicit memory. And you can see the role of hippocampus in case of episodic memory. Okay, right. So thalamus, again, not involved. Amygdala, again, the role of amygdala is in emotional memory. Okay, that is again coming under implicit only, right? So that is not the answer. And also, cingulate gyrus is again not a predominant structure in explicit memory. The answer is option A. Another favorite repeat question. On MRI, the eye of tiger sign is characteristic of which of the following conditions? Options are Wilson's disease, pantothenate kinase associated neurodegeneration, Huntington disease, and Krabs disease. Let us have a look at the options. First, coming to Wilson's disease. We know that in Wilson's disease, you get the face of giant panda appearance, not the eye of tiger. The eye of tiger appearance is associated with pantothenate kinase associated neurodegeneration, which is PCAN, pantothenate kinase associated neurodegeneration. pecan, and this is this was previously referred to as Hallerwarden-Spatz disease. So basically, this is coming under the umbrella of neurodegeneration with brain iron accumulation, which is NBIA. So eye of tiger sign, option B is correct. What about Huntington disease? In Huntington disease, you get the boxcar ventricles. Krebs disease is leukodystrophy. You get white matter hyperintensities predominantly involving the parietal and occipital lobe. The region of the corticospinal tract is predominantly involved. So Krebs disease also I am eliminating, right? So the answer will be option B, pantothenate kinase associated neurodegeneration. Can also see the images. This one is the eye of tiger appearance. Eye of tiger appearance. The next one, you can see this is the face of giant panda. Face of giant panda. Okay. And here you can see the boxcar ventricles as well. All right. So that's it. The answer is option B. Coming to the next question. A contrast enhanced CT scan of a child presenting with seizures is provided. Based on the imaging findings, what is the most likely diagnosis? So the patient has presented with seizures. No other details given in question. Imaging finding. Is it brain abscess, tuberculoma, neurocysticercosis, or is it cerebral metastasis? So what is that you see on the imaging? You can very well see a ring enhancing lesion, correct? A closed ring enhancing lesion. And look at the options: brain abscess, tuberculoma, neurocysticercosis, cerebral metastasis. All of them can have ring enhancing lesions. But what is the differentiating point here? You can see this is a small ring enhancing lesion. And if you closely observe, can you guys spot scolex? So it's essentially a cyst with scolex. A cyst with scolex. And can you guys tell me, where do you get cyst with scolex? So this is seen in the vesicular stage of neurocysticercosis, right? Vesicular stage of neurocysticercosis. So the answer for this question will be neurocysticercosis. Brain abscess, you would get a larger lesion and you will be able to see the central, area of pus as well. That is not what you are seeing here. Tuberculoma, again, ring enhancing lesion possible, but mostly you will get conglomerate. Multiple such lesions will be there. Just like this, multiple lesions will be there. You will get conglomerate lesions in case of tuberculoma. So since that is not there, I am not considering it as the first possibility. Then cerebral metastasis, again, child with seizures, that is again not my clinical possibility here. Answer is option C, neurocysticercosis. Coming to the next question, a 30-year-old woman was treated with carbamazepine for new onset seizures. She was also started on erythromycin for respiratory infection. So we have got a patient who has been started on carbamazepine recently and also for a respiratory infection being started on erythromycin. Okay, right. And you can see that the question is the patient has developed dizziness and ataxia, and which of the following is the most likely cause of her symptom? So what could be the reason why the patient has developed dizziness and ataxia? What could be the reason? There must be some drug interaction between carbamazepine and erythromycin. So you very well know that this erythromycin drug can actually act upon certain cytokine enzymes. So you know that this is a CYP3A4 inhibitor. Yes, and because this is an inhibitor, it can cause accumulation of carbamazepine. It prevents the metabolism of carbamazepine, resulting in its accumulation. Accumulation will cause toxicity. So essentially, the symptoms of dizziness and ataxia in this patient could be a manifestation of carbamazepine toxicity because of the drug interaction. So the answer for this question is carbamazepine toxicity due to drug interaction. Regarding other options, erythromycin-induced neurotoxicity? No. Rebound epileptic episode from medication non-compliance? Well, that is not what we are seeing, right? The patient has got dizziness and ataxia. I'm eliminating that as well. Then drug-induced cerebralitis. We know that certain cancer chemotherapeutic drugs can cause cerebralitis, but not the drugs that are given in the question here. So answer is option A. Coming to the next question, a patient with lupus nephritis and biopsy showing wire loop lesions, very important, is started on induction therapy. Which of the following agents are recommended for the induction treatment? So patient with lupus nephritis with wire loop lesions. Where do you get wire loop lesions? I've told you about the classification of lupus nephritis: class 1, class 2, class 3, class 4, class 5, and class 6. Yes. Now, wire loop lesions are more commonly associated with class 4 lupus nephritis. Class 4 lupus nephritis. Now, for induction treatment, what is recommended is the question. Now, let us quickly summarize about the management of lupus nephritis. When the disease is limited to the mesangium, as in case of class 1 and class 2, the patients usually have got excellent prognosis and no specific therapy is required. Maybe you can give some sort of angiotensin receptor blockers to retard the proteinuria if needed as a supportive treatment. Regarding class 3, you can subdivide into mild and severe. A mild class 3, you need to give only steroids, whereas a severe class 3 lupus nephritis is treated as class 4 lupus nephritis. So coming to the management of class 4 lupus nephritis, this has to be treated aggressively. You've got an induction phase wherein you give high dose steroids with cyclophosphamide or mycophenolate mofetil. This is in induction phase. And in the maintenance phase, you can go for MMF or azathioprine. Other approved add-ons include voclosporin and belimumab. And in refractory cases, you can give rituximab. Okay, rituximab. Right. So that is what you should be knowing about management of class 4. So you can see in this question for the induction treatment among the options, well, high dose steroids with cyclophosphamide will be the best answer. Steroids alone will not be enough. Rituximab can be given, but that is only for the refractory cases. But the question is specifically on induction therapy. Mycophenolate mofetil alone, again, not a preferred drug for induction treatment. Just for the completion's sake, class 5 lupus nephritis, you can go for immunosuppression, but since there is high chance of development of thrombotic episodes, anticoagulation may also be needed, especially in patients who have got the antiphospholipid antibody positivity as well. Coming to class 6, you can go for dialysis or renal transplantation as a part of the management. So for this question, without any doubt, option B is the right answer. Which of the following is not a risk factor for recurrent nephrolithiasis? Options include hyperoxaluria, hyperuricosuria, hypercalciuria, and hypercitraturia. See, I've highlighted this point in my lectures as well. Citrate in urine is actually an inhibitor of calculi formation. So hyperoxaluria, uricosuria, calciuria all can predispose to stone, but not hypercitraturia. That's actually protective for renal calculi formation. Option D is the right answer here. Coming to the next question, a 35-year-old woman presented with colicky abdominal pain and is diagnosed to have ureteric stone What is the best diagnostic investigation? Favorite question, repeat question, has been asked many a times. It is non-contrast CT KUB. That's going to be the answer here. Coming to the next question. A 60-year-old male presented with complaints of increased urinary frequency and burning sensation while urinating for the past 1 month. On examination, the prostate is found to be normal. Watch out. On examination, prostate is found to be normal. There is no prostate tenderness, but tenderness is noted in the suprapubic area. The urine analysis shows elevated WBC count with the urine culture revealing no bacterial growth. Now, what do you call this? With elevated WBCs but culture showing no bacterial growth. So this is called sterile pyuria. This is called sterile pyuria. Yes. And what is the most probable diagnosis is the question. Well, you can see option A, B, C, all prostatitis related. And it has also been mentioned in the question that the prostate is found to be normal. So it is unlikely to be any of these options, right? The tenderness in the suprapubic area is likely due to cystitis. So the patient is having a sterile pyuria due to cystitis. And we very well know that sterile pyuria can have a lot of causes, maybe a partially treated UTI, TB, tuberculosis of the genitourinary tract, renal calculi, all can result in sterile pyuria. So for this question, the best answer would be option D, sterile pyuria. Coming to the next question, which type of pulse is based on Frank-Starling's law? Is it pulsus bisferiens, paradoxus, alternans, or pulsus parvus? So the answer for this question is going to be option C, pulsus alternans. This is the pulse character abnormality that is seen in patients with severe LV systolic dysfunction. Very important. In patients with severe LV systolic dysfunction. Now, what happens when there is severe LV systolic dysfunction? Now, according to Frank-Starling's law, you know that the force of contraction is proportional to preload. And what is the preload? The preload will be end diastolic volume. So what happens in the setting of a severe LV dysfunction is that one of the beat, because of the LV dysfunction, may eject less blood. So which means for the next beat, more blood would remain in comparison to the first beat. That would increase the preload for the next beat, resulting in a stronger contraction. So that would result in alternating cycles of strong and weak contractions. This is what is referred to as pulsus alternans. So for this question, option C is the answer. Pulsus bisferiens may be seen in the context of aortic regurgitation and hypertrophic obstructive cardiomyopathy. That is not the answer. Pulsus paradoxus. So pulsus bisferiens is two peaks in systole, right? Two peaks in pulse character in systole. Pulsus paradoxus is an inspiratory fall, exaggerated inspiratory fall of the systolic BP, as you can see in conditions like cardiac tamponade, bronchial asthma, exacerbation, multiple other conditions. Pulsus parvus, it's seen in case of aortic stenosis, where you have got a weak pulse, which also will peak late. Okay, so that is in aortic stenosis. Let's move to the next question. The murmur of mitral stenosis is best correlated with which part of the ECG? The options are QRS complex, T wave, P wave, ST segment. It's relatively a simple basic question. And if you look at this image of the ECG, well, you know that in mitral stenosis, what sort of murmur you get? Mid-diastolic murmur. So you please note the phase of diastole, that is the ventricular diastole. It's an MDM murmur that you get, mid-diastolic murmur. Now you look at the options. Okay, now you look at the options. QRS, T wave, P wave, ST segment. You can very well see that this is most likely correlating with the P wave. So answer for this question will be option C. That will be P wave. All the following are features of heart failure except orthopnea, paroxysmal nocturnal dyspnea, non-pulsatile elevation of JVP, and right hypochondriac pain. This is again a repeat question. So we very well know that orthopnea is a feature of heart failure. PND is a feature of heart failure. Right hypochondriac pain is also a feature of heart failure. Because of the congestive hepatomegaly, you can have a right hypochondriac pain. So the answer here will be non-pulsatile elevation of JVP. That is not a feature of heart failure. It is commonly seen in patients with SVC obstruction. SVC obstruction. Option C will be the answer. A 40-year-old patient who is a chronic smoker presents with complaints of shortness of breath. Pulmonary function test shows an FEV1 to FVC ratio of 65% and RV to TLC ratio of 141%. Which of the following most accurately describes the underlying pathophysiological process? Options are air trapping with hyperinflation of the lungs. Option B, restrictive lung disease. Option C, decreased lung compliance. And option D, normal age related change. So the point here, what you have got to note is FEV1 to FVC ratio of 65%, which means it is reduced, is suggesting we are dealing with obstructive lung disease. Correct or not? Obstructive lung disease. And RV by TLC ratio, this is definitely elevated, which means there is so much of residual volume, again suggestive of an obstructive lung disease like COPD. Okay. Now, look at the options. One option is restrictive lung disease. No, in restrictive lung disease, the FEV1 to FVC ratio is normal or elevated. Decreased lung compliance, again, seen in case of restrictive lung disease. This is not a normal change. So the answer is air trapping with hyperinflation of lungs. This is just what happens in case of COPD emphysema. So answer is option A here. Coming to the next question, which one of these statements about pneumothorax is incorrect? Option A, in hospital, the most common cause of tension pneumothorax is positive pressure ventilation. It is correct. In hospital, that is correct. I have to pick up the incorrect statement, right? Injury to the thoracic spine can lead on to pneumothorax. Again, possible. There can be injury to adjacent pleura and lung, possible. On the affected sites, breath sounds are absent. Very true. A simple pneumothorax cannot evolve into a tension pneumothorax. That is wrong. It can evolve. When there is a persistent air leak, that may get converted to tension pneumothorax. That is an incorrect statement. Option D is the correct answer. Rapid ascent to high altitude most commonly results in which of the following disturbances? Option A, respiratory alkalosis. Option B, metabolic acidosis. Option C, metabolic alkalosis. And option D, respiratory acidosis. So when you have got a rapid ascent to high altitude, okay, rapid ascent to high altitude, this would result in hypoxia. This would result in hypoxia. And when you have got hypoxia, what is going to be the response? You can have hyperventilation. When you have got hyperventilation, what happens? There will be carbon dioxide washout. And when there is carbon dioxide washout, this can result in respiratory alkalosis. Respiratory alkalosis. So for this question, simple, straightforward, it is option A, that is the answer. Coming to the next question, a 60-year-old male presents with worsening breathlessness and bilateral pedal edema. He is adherent to his antihypertensive medications and his blood pressure remains well controlled. Echocardiography reveals an ejection fraction of 60%, concentric left ventricular hypertrophy, left atrial enlargement, and grade 2 diastolic dysfunction. Which of the following is the most appropriate next step in the management? What are the options? Option A, perform coronary angiography to rule out ischemic cardiomyopathy. Option B, initiate loop diuretics and SGLT2 inhibitors. Option C, initiate ivabradine to reduce the heart rate and to improve diastolic dysfunction. Option D, start digoxin to enhance myocardial contractility. So we have got an elderly male presenting with worsening of breathlessness and bilateral pedal edema. This could be due to heart failure. You can see that the echocardiography is showing an ejection fraction of 60% with concentric left ventricular hypertrophy. Well, we are probably looking at a heart failure with preserved ejection fraction. Very important. Heart failure with preserved ejection fraction, right? So you can see that there is left atrial enlargement and there is diastolic dysfunction. So probably the left ventricular filling pressures are high, and because of which there is left atrial enlargement as well. Now, what is the next step in the management of this patient? Let us look at option A. Perform coronary angiography to rule out ischemic cardiomyopathy. Is there any mention of chest pain in the question? Is there any mention of ECG changes suggestive of myocardial infarction in the question? Is there any other strong pointer hinting towards an ischemic heart disease? No. So in that case, this step will not be the next line. Next one, initiate loop diuretics and SGLT2 inhibitors. Now, when it comes to heart failure with reduced ejection fraction, I have taught you in my lectures regarding the Fantastic Four. You remember? Yes, the ARNIs, or you can even use AC inhibitors or ARBs, the MBC beta blockers, the SGLT2 inhibitors, and the mineralocorticoid receptor antagonist, the Fantastic Four. Now, when it comes to heart failure with preserved ejection fraction, the data in supporting these agents are relatively limited. But with the available data, the evidence is more strongly favoring the use of SGLT2 inhibitors. So SGLT2 inhibitors have got proven mortality benefit in patients with heart failure and preserved ejection fraction. You can also consider giving loop diuretics along with that in this patient. So this definitely is one option that I will consider as the answer. Let me just go through the other option as well. Initiate ivabradine. Well, the role of ivabradine in heart failure is mostly for heart failure with reduced ejection fraction, not preserved ejection fraction. And even in reduced ejection fraction, not as first line, but still in it can be considered as one of the possible options. So I'm eliminating this as well. Coming to option D, start digoxin to enhance myocardial contractility. Well, the role of digoxin as well is for heart failure with reduced ejection fraction, and that too not again as a first line, mostly in the context of a patient having atrial fibrillation also along with the heart failure. But in a preserved ejection fraction patient with no mention of AF, this is not a management strategy that I would consider as the next step. So considering all these factors together, what is going to be the answer? Option B, initiate loop diuretics and SGLT2 inhibitors. Option B will be the answer. Coming to the next question, a patient in ICU develops ventilator-associated pneumonia and serum procalcitonin is measured. Which of the following statements about procalcitonin is correct? So the question is regarding the biomarker procalcitonin. Okay, in a patient with ventilator associated pneumonia. Look at the options. It helps in determining the duration of antibiotic therapy. Option B, it guides the choice of initial empirical antibiotics. Option C, it confirms the source of infection. Option D, it differentiates bacterial from fungal infections. So let us see the options. Option A, It helps in determining the duration of antibiotic therapy. Now, this for me looks correct because when you start a patient on ventilator associated pneumonia on antibiotics, when you measure the procalcitonin, it is giving you a rough idea on whether you can de-escalate the antibiotic or not. Okay, so it definitely will help you in determining the duration of antibiotic therapy. What about the remaining options? It guides the choice of initial empirical antibiotics. Absolutely wrong. You cannot decide on what is the empirical antibiotic therapy based on procalcitonin levels. Option C, it confirms the source of infection. What is the organism? Can you make any comment based on that? No, that is also wrong. It differentiates bacterial from fungal infections. Well, procalcitonin levels are mostly elevated in bacterial infections, but you cannot take it to be a concrete evidence to differentiate between bacterial and fungal. So for me, I would also eliminate this option. So the best option here will be option A. It helps in determining duration of antibiotic therapy. A 40-year-old woman with a diagnosis of septic shock has a BP of 58 on 30 mmHg. Despite receiving 3 liters of crystalloid fluids, her mean arterial pressure remains at 60 mmHg. What is the most appropriate next step in her management? So essentially, the question here is on the management of septic shock. So we know that for the management of septic shock, sepsis control is important. Yes, you will have to give broad spectrum antibiotics. You will have to give IV crystalloids, normal saline, which has already been given in this case. And the next step will be vasopressor. And the preferred vasopressor, which I've told you, is norepinephrine, with the target of keeping the mean arterial pressure above 65 mmHg. Look at the options. What about option A, dopamine? Can you give dopamine? So, in the setting of a septic shock, dopamine is not that preferred because dopamine, there is a higher risk of arrhythmias in comparison to that of the norepinephrine. So, this I am eliminating. Okay, this I am eliminating. Initiate noradrenaline. Yes, that is the option that I am considering. Noradrenaline or norepinephrine. Administer additional crystalloid fluids. So already 3 liters have been given, and if you pump in again IV fluids, there is a chance of development of pulmonary edema. Next option, vasopressin. So vasopressin can also be considered, but it is not a first line. You can consider it as an adjunct to norepinephrine, but that is not going to be my first choice pick. So for this question, option B will be the answer. Coming to this question, a 56-year-old male, known case of diabetes, presents with complicated urinary tract infection and is found to be hypotensive. So here again, a complicated UTI with hypotension, we are again dealing with a scenario of septic shock. Septic shock. Okay. And his BP is not responding to IV fluids. What is the most appropriate antibiotic for managing this condition? So we know that in the setting of septic shock, you've got to address the sepsis. So broad spectrum antibiotic has to be given. And in the setting of a complicated UTI, you will have to deal with organisms producing extended spectrum beta lactamase as well. Organisms like E. coli. So among these antibiotics, what is that which is effective against ESBL? Not amoxicillin clavulanate, no. Not nitrofurantoin, not even ceftriaxone. The answer here will be option C, meropenem. That will be the answer here. Best modality for localization of parathyroid adenoma. Again, a repeat question. We know that the technetium 99 sestamib scan is the best modality for localization of parathyroid adenoma, And option C clearly is going to be the answer for this question. Most common type of pituitary tumor. Is it growth hormone secreting adenoma, prolactin secreting adenoma, ACTH secreting adenoma, and non-functioning pituitary adenoma? Most common pituitary tumor. That is the question. Now, though in terms of clinical presentation, it will be prolactinoma, but overall, if you see, the most common type of pituitary tumor is the non-functioning pituitary adenoma. That can also be symptomatic, when you've got the mass effect. Okay, but otherwise, in terms of hormone production, prolactinoma, but overall, it is non-functioning pituitary adenoma. Option D will be the answer here. Which of the following contributes to the development of hyponatremia in a patient with diarrhea? Is it decreased aldosterone? Is it decreased sodium absorption from the GIT? Is it increased sodium absorption by the kidney? Or is it increased antidiuretic hormone? Something which we have discussed time and again in the module on hyponatremia as well. So essentially what happens is when you have got a patient with diarrhea, you've got loss of sodium and water. Yes, you've got loss of sodium and water. Clear? No doubt about it. You have got loss of sodium and water. Now to compensate, you will have secretion of ADH. Because of the dehydration, you will have production of ADH, right? And this ADH will cause the reabsorption of water. And this can cause a dilutional hyponatremia. So for this question, the answer will be option D. Which is the most common clinical feature of SLE? Is it photosensitivity, nephrotic syndrome, arthralgia, myalgia, or is it anemia and thrombocytopenia? Well, all these are possible clinical manifestations of SLE. The question is specific regarding the most common manifestation. If we can look at this table from Harrison on the spectrum of manifestations in systemic lupus erythematosus, you can see that musculoskeletal manifestations, 95% of cases. Okay, you can see. Photosensitivity, so myalgia, arthralgia, they are all musculoskeletal manifestations. Photosensitivity, skin manifestation. Mucocutaneous is 80%. Hematological manifestations is again 50%. Renal manifestations again 50%. So I've highlighted the four options as well, right? So for this question, what is going to be the best answer? Arthralgia and myalgia. The musculoskeletal manifestations are the most common clinical feature of SLE. So that's it. We have come to a conclusion of the discussion of the recall questions. Thank you so much.